essential to our everyday life. And the thing that is fascinating about speech signals, at least to me, is that they convey a lot of information simultaneously. So here, what I'm showing you is a picture of a waveform for this sentence.
Congratulations, you're hired.
So I'm assuming everyone can hear the sentence. So from this just very simple sentence, we can get the information about what information I refer to as what information or the linguistic message that you're going to get a job. Okay. And at the same, and we refer to this process as speech perception. And at the same time, you probably also can get information about the speaker, or what I refer to here, the who information. So probably we get something about the emotion status of the speaker. And she's probably very happy. She's going to offer you a job. She's probably very happy. And I refer to this process as emotion perception. And both speech perception and emotion perception, they are very, very important for our everyday communication. And these are the two topics my lab focuses on. And specifically, my lab is very interested in the widely accepted finding that advanced age is associated with a decline in spoken communication. So, and we believe this is an important area to pursue because a decline in spoken communication has been linked to increased social isolation and loneliness, and which in turn are linked to accelerated cognitive decline in the elderly. But as we kind of research this topic, one thing that's kind of complicated things is that aging often co-occurs with hearing loss, as indicated by the figure here. As people get older, their hearing tends to become poor. And we know that hearing loss is detrimental to our spoken communication skills. And my lab is specifically interested in spoken communication in a group of older adults. They have moderate to profound hearing loss, and they choose to go through surgery to have a cochlear implant inside their ears to hopefully to treat hearing loss to partially restore hearing. Okay. So just as a reminder, throughout this talk, I will use the acronym like CI to refer to cochlear implant. And because of the baby boomers, everything is getting older, so the number of older CI patients is projected to keep growing. And here, just like one of the data points from Johns Hopkins, their side, to showing this kind of continual increase in trend. And cochlear implant are currently the standard treatment for patients with hearing loss when their hearing aid does not provide adequate benefit. And the benefit from cochlear implant include, but not limited to, the things I'm going to mention here. First is you can partly restore hearing. So just remember, it's only partly restore hearing. So for both like speech perception tasks and also for emotion perception tasks. And with the restoration of hearing, that comes to the improve like quality of life and the reduced degree of anxiety and depression. And there are also some studies interested in whether those hearing intervention can improve cognitive outcomes in older adults. But I put the asterisk here because based on reading of the literature, it's still kind of a debate going on whether it's improved or no improvement. So just keep that in mind. These are all great benefits, okay? But what I would like to do is to spend it for the rest of the talk is to discuss some potential limitations, or maybe another way to put it is the room for improvement when you try to use cochlear implant to restore hearing in older adults, okay? So the first challenge is, which I think is not surprising to us, is that aging still play a big role. When we think about the performance here. So aging, as shown from this data here, advanced age in those older CI patients is associated with a decline in spoken communication for speech perception tasks, different kinds of speech perception tasks as shows here. So you can see a drop or gap for older adult in the gray color versus the younger adult CI users. and also for the emotion perception task. So we generally see this aging effect still persist when you think about spoken communication in this adult CI patient, okay? So can we do something? Can we reverse this? Can we reduce this such age recap? Because they go through this surgery, it's expensive. There's a lot of things going to have a surgery have cochlear. Can we reduce that gap? So for this talk, what I want to try to focus on is we talk about some studies from my postdoc with the goal to try to uncover some of the mechanisms for such age-related decline in spoken communication. Hopefully that can provide some insight into where we should go in terms of intervention to reduce this like age-related gap. But before I dive into those two studies, I want to spend some time to discuss something about the cochlear implant, because I feel like this is probably the area not everyone is very familiar with. So, like I said, the purpose of cochlear implant is to restore speech understanding for people with moderate to profound sensory neural hearing loss. It's like something happens as more like the inner ear or the optional inner ear or optional at that level. And here, just a very quick overview of how this works. So first, there's a microphone here, as indicated here. There's a microphone to pick up the sound in the environment. And then there's a processor from this cochlear implant will kind of computerize, analyze the signal, convert into digital signals, okay? And then you will send through a coil and go inside some receiver inside the skin, which is like around here, okay? And the receiver, and there's some processing going on, try to convert this digital signal into some electric pulses, sent to some electric pulses, those electrodes inside the cochlear, okay, which is the hearing organ there. And then what they do, those electric pulses will try to stimulate the arch nerves, like arch nerves. Hopefully from there can generate a hearing sensation, okay? So CIs are effective, has helped a lot of thousands of people, but they are far from perfect. And CI only provide like degraded or coarse signal to the listeners. In fact, when it was first introduced, few people believe it will work, because you just have like 18 to 22 electrode. You just still plug it in the ear and you just provide some electric stimulation. How could that deliver hearing sensation, given that we have like I have thousands of arch nerves kind of do that work in the normal hearing people? How could you like replace that with only like 18 to like the 22 or 24 electrode? So few people believe it works, but it turns out it works. Okay. So now what I want to try to highlight here is some of the changes that can occur when you get a cochlear implant. What does this cochlear implant do to the signal that provide to our brain, which is a huge obviously constraint that we should take into account when thinking about spoken communication in cochlear patient. So what am I showing here in the middle here is a normal typical waveform. Our normal people, normal hearing people will receive. Has a lot of information is there. If you simply divide that, you can have an envelope, which is those slow varying changes, okay? We also have some fast changes inside. So if you do like very simple division of the information from this signal, and what cochlear implant does to this is that it will remove those fine structure, what I refer to as spectral details of the speech signals from this full waveform, and only deliver envelope to a listener. So what that means, like visually, is that if this is what we saw, like normal people with normal vision, you have a full detailed tower, looks very beautiful. And then what it does for cochlear that it remove those details of this tower, only give you a gross contour. You know there's something like a tower, but you don't know the detail. There's a clock, there's something else. You don't know about this because the cochlear does not provide those information to a listener. And here just another information, another kind of example to show here. On the left side, you have original speech waveform. This is a spectrogram, which basically shows you how the frequency information change across time. What I want your attention is there is a lot of those horizontal stripes, okay? So those are the fundamental frequency, the harmonics. Those are the very important spectral details, very important for identifying a speaker, like, and also like in like tonal language, like you carries as linguistic meanings. So those spectral details are very, very important, okay? And also for speech understanding in noise situations. But if you look at the CI process signal, we barely can see those stripes in this signal, which means that those spectral details, very, very important for speech understanding, and are lost in the process of this cochlear implant, okay? And one of the consequences is that because those spectral data are lost, some listener need to rely on what I refer to as a temporal information for speech understanding, which is basically the information, the simple information kind of across time. We need to rely on those information for speech processing. So here I would like to give you one more example to kind of show you how degraded the signal are passing through a cochlear implant. So here is the visual analog about the kind of resolution you will get of the information when you think about the information delivered to cochlear implant. Okay. And what I want to do is kind of do a kind of president game. So these are some images of the American president. You guys probably know better than me. Okay. So imagine this is what the cochlear implant will get in terms of resolution of the information. So if I give this is what cochlear implant will listen or will see. So if you want to guess what the name of the president. So probably it's slightly difficult. If you first time saw it, it's slightly difficult to kind of to know the name of the president. If I increase a little bit the resolution, probably you have some idea. And if this what we normal person will see, this is Bill Clinton, right? And we can do the same thing. Like this is what cochlear implant a patient would like have this kind of only have this kind of resolution. Very difficult to see when you saw the first time. And for normal vehicle is just a very easy task. Okay, we can do the same thing. This Barack Obama, and same thing here, right? So what I want to like to convince you here is that cochlear implant first it only presents you with information that has a lot of information being lost, has minimal resolutions. Okay, and as you show here, but with your knowledge and with training, we are able to kind of learn those kind of information, learn those kind of picture, or learn those kind of sounds. So we are able to achieve a good perception, just like with those pictures, okay? And that's very important to think about like how a cochlear implant can work, can restore hearing. But sometimes it may be difficult. If I give this picture, this is another president, if you're not very familiar, and then it's probably very difficult for you to easily kind of to name this president. So this means that when the things are when speech signal are distorted or unfamiliar, like accident speech, or like when speech signal is in a noise environment, like you go to a restaurant, go to a bar, things will become especially difficult for cochlear implant listeners because they only get this minimum resolution of information, and it will be very kind of difficult for them. Okay, so this is another, I would say, like maybe unique challenge from a cochlear implant, that the information that delivered to listener only have this minimum resolutions. Okay, so they're pushed to rely on only this the changes, what I refer to as temporal information for speech understanding, okay? And that has a huge implications thinking about in the context of aging, which I will talk about in the next slides, in the next few slides. And so in the context of the aging and speech education, my first line work, what I'm interested in is aging and the impact on auditory emotion perception in cochlear patient. So this is a newly developed line of work. So one of the rationale we want to study this topic is because, as you probably vaguely remember, I showed you the spectrograph is that the horizontal stripes, which contain the fundamental frequency or those voice pitch, those information are very important for emotion perception. They are kind of lost or severely degraded in cochlear implant through the cochlear implant. So those cues are not well received or delivered to the cochlear implant patient. So that's one rationale. And the other rationale is that tons of studies from acoustic hearing people just like us, showing that aging is associated with a decline in the neuroencoding representing those voice pitch cues. So this led us to think about the consequences of those for all the cochlear patients in terms of emotion speech perception. And this is, like I said, this is a new line of work. I'm collaborating with researchers from Boystown to develop our one grant proposal on this topic. We'll try to plan to submit like next spring. So hopefully I have the chance to report back what we found from this new project. But what I would like to focus on, like for the rest of talk, is focusing more on the speech perception side of the work, what I have done like previously. So so the big question here is that we are seeing this age-related decline in terms of speech perception in cochlear implantation. So, but we don't have a good understanding why, what's causing this like age-related gap. Because, and if we want to help them to reduce this gap, probably we need to have a basic understanding about the mechanism here. Okay, so and that's one of the focus about the research I've done since my postdoc, and we also continue this kind of work. And here's a framework has been widely used in the hearing and the aging domain to try to understand the impact of aging on spoken communication. So we have peripheral auditory process function and the central auditory function and the cognitive function. They all contribute to spoken communication abilities. And on top of that, in terms of thinking about cochlear patients, that we have those cochlear implants that can only provide degraded signals. So that is much of the spectral details of the speech information is being lost here. So also this is another layer of factor we need to think about when trying to understand the impact of aging on speech communication. So for my study, one of the goal here is to determine age-related changes in auditory temporal processing, which is an important auditory function, as the potential mechanism underlying the age-related decline in speech perception in cochlear patients. So just give you a very quick kind of introduction of what do I mean like auditory temporal processing. It basically is the ability to process temporal features, for example, gaps in the auditory or speech stimuli. So what I'm showing you on the screen, I have two words. On the left side, you have the word dish. On the right side, I have another word called ditch. So the top are the kind of the spectrogram, the bottom is the waveform. So what differs between those two words is this silent gap between the final consonant sh. So this is the final consonant sh. Okay. So what differs between those two sounds is that this silent gap, because you see this is a flat line, which means there is minimal energy. This is a silent interval. You can see the ditch has a longer silent duration, and dish basically has a zero silent duration. So those gaps, those time gaps, temporal gap, they mean something. We use that for categorized sounds. They give rise to different sounds. So those are very important. And so, and tons of studies from the acoustic hearing, like study people like us, have showed that this ability will predict people's speech understanding or speech perception performance. So that's one of the rationale why we focus on this this domain of ability here. Okay. So hope you have some idea what do I mean by auditory-temporal processing. So the big question here, before we can jump into say, okay, this auditory-temporal processing can bring is a mechanism for age-related speech understanding decline in cochlear patient. We need to establish firm evidence, a solid evidence to say that all the adult CI users, they do experience this auditory-temporal processing deficit. They do have those kind of deficits. Then the next step is for us to see that predict their speech communication or speech perception declines. So that's the question I want to ask here, and I want to present two studies, kind of try to provide evidence to answer this question. Do all the adult CI users experience auditory-temporal processing deficit? So that's the question I want to ask here. So here are some information or some ideas we can gather from the previous literature is that auditory-temporal processing deficit occur in older acoustic hearing adults, like those persons just use their ears to do the hearing instead of using the cochlear implant. So we are seeing a deficit there, and then in terms of thinking of the cochlear implant, it conveys primary temporal information, okay, and so they must rely heavily on those temporal cues for successful understanding, which means that it may make them particularly susceptible to this age-related temporal processing deficit, because they need to use it. That's the primary cue they can use. And with the aging process, like judging from the literature of all the acoustic hearing literature, seems there's age-related process changes going on that can give rise to these deficits. So based on this evidence, our hypothesis is that CI patients should be particularly susceptible to age-related temporal processing deficit. And then to test this hypothesis, I will describe briefly, can I give you a quick overview of two studies from my postdoc to try to get into this question. So in the first study, we used, this is a behavior study, we use a very standard typical way to assess auditory-temporal processing. It's called a word categorization task. So let me just give you a quick overview about exactly what we do here. So first, I'm going to introduce you the stimuli. So remember, I gave you the dish, a ditch, word, and they differ by the silent duration cue here. So what we do here is have those two naturally produced words, and we make a hybrid word dish, and then we manipulate the duration of gap in between the syllable D and the final consonant sh, okay? And listener and this create a 7-step continuum of silence duration cue, okay? Listener, this is the only cue listener will use to differentiate those words, okay? And listeners tend to perceive words with a shorter silent duration at this, a longer silent duration at this, which is not surprising. And what we do is each time we present them with one word, and they need to make a judgment whether it's a dish or dish. Like say, oh, hey, this is a dish, and this is a dish. So we just repeat this a lot of times. And then what we can do is plot the percentage of dish as a function of the silent duration cue. And then we can have a psychometric function plot here. So here I'm showing you is two hypothetical response patterns from a hypothetical good performer and hypothetical poor performer. Like the good performer is in blue and the poor performer is in red. Okay. So what we can do is you can fit psychometric function and derive two metrics. The first metric is called 50% crossover point. It's basically the duration or the length of silent duration where person will have 50% of a dish responses. you can see the hypothetic proof performer has a delayed or need a longer silent duration to differentiate those words. And then the other metrics is slope. Okay, you can see that the proof performer has a shallow slope, which means that they have difficult time kind of differentiate, characterize those two sounds. Okay. So these are the kind of the paradigm we use to assess this auditory temporal processing abilities. And based on previous study, this is our hypothesis. So older adult CI patient or users will show later crossover point and shallower slopes. And to test this hypothesis, we have 3 groups of people. Just give you kind of not a heads up. It's just like in the cell literature, this is one of the biggest sample size we can get, like for a single site. This is just maybe a limitation, it's just a constraint of this type of study with patient you can get. That's just want you know that. And we have those 3 groups of people, and here are some of them demographics. One thing I want to highlight here is that duration of deafness and duration of CI use, and those 2 factors has been shown to predict speech perception performance, which we didn't like try to control by ourselves. It happens that the subject we recruit, they're not significantly different across those 2 factors, which is great. And they're native speak American English, they need to pass a cognitive screening based on here use the MOCA. And we also try to present the sound here at different level, try to kind of to simulate like people may hear sound at different levels. And for the result, I'm going to focus on just 45, 65, and 85, those 2 levels. Okay. So here are some of the results. I'm plotting the percentage dish as a function of silent duration. So you're going to see 3 different lines. Okay. So at 45 dB, the 3 lines, which means the 3 groups, they pretty much overlap each other, no difference. And 65, still no difference, which kind of surprising kind of to us. When we saw this finding is that only at 85, see those mid-aged and older adult, they have this shallow slope, which, as I mentioned earlier, show which may indicate they have a poor temporal processing versus the younger CI users. I'm gonna skip why 85, but if you're interested, I'm gonna explain a little bit like what do we mean by why do we see 85. We have some explanations here, but we are seeing some evidence that at least at the high presentation, when we present the sound very loud, relatively loud, we are seeing this temporal processing definitely of the changes here. Of course, when we extract those metrics, not surprisingly, we are seeing those delayed crossover point and shallow slope for the older versus younger CI users. Okay, so trying to kind of to put together what I just said, we found that older CI users show the poor auditory temporal processing as indicated by this word characterization paradigm, but only at higher presentation levels. Okay. So this kind of concludes my first study. We have this behavior study, try to tackle this question: do older adult CI users experience auditory processing deficit? And the next question is, the next study is an electrophysiological study. So because with behavioral paradigm, there's can be a lot of more factors like your attention, motivation, cognition. A lot of those factors may play a role here, which is very difficult for us to disassociate here. So we want to try maybe some passive paradigm with some electrophysiological responses, like specifically event-related potentials, to help us to look at this question like from another angle. So what we do here is very typical standard classic paradigm called auditory evoked potentials. Okay, so imagine this. Of course, this is not a real Cochlear listener. I just give example. They wear this cap. We record the brain signals. So we present the sound a lot of times. Okay, multiple times, like 2-3 repetitions. and then as a comfortable level, and then we can record some raw signal. After we do some processing, we can get a cortical auditory potential. Okay, this is just an example. We mainly focus on the responses from those more temporal, central electrode, because those are the auditory responses tend to be the most prominent. Okay, and this is the waveform we'll be looking at. Okay, so this is just a enlarged view of the waveform. Based on previous studies, we look at the P1, N1, P2, which start to reflect the detection of the time-varying acoustic cues at the level of the auditory cortex. And we are focusing on latency here, basically the neural processing time, the timing of those responses here. So P1 has about like 50 milliseconds, N1 about like 100 milliseconds, P2 like about 200 milliseconds. And they are start to reflect like different processes. Like for example, P2 is like early processing of the signal as an auditory object. Okay, so this is our metrics we're going to use to look at the latency of those responses. So based on previous studies, our hypothesis is that the older adult CI users will show a prolonged or delayed or longer those latency for the P2 of their responses. Okay. And we have two groups here. So here we have a really smaller group here to test this. We have a younger, actually it's younger to mid age, just for simplicity, I call it young YCI here. Okay. And also have old CI, older CI users. It just happens that they don't differ on duration of deafness, duration of CI use, which is great for us. Although we haven't, it's very difficult to manipulate, but it's just turns out there's no difference. They also need to pass a screening native in speakers. Okay. And one other thing we add to the design here is that we try to present the stimuli at different intervals. I will just leave it here. We have some rationale why we want to do this, but I will leave it here. It just let you know we have this factor as a design. But if you're interested. Okay, so I just leave it here, but if you're interested, I can explain why we include this factor. But for now, you just know we have this factor into our design. And we also have like two stimuli. One is very simple, like 1,000 Hertz tone. The other is a syllable da. Okay, and the hypothesis here, based on previous studies, that more complex stimuli tend to have a higher chance, or tend to be more pronounced age effect here. So that's kind of the hypothesis here. So what I'm showing here are the waveforms to the sound, to the speech sound, and also to the tone. If we can just zoom in, focus on here as one of the intervals, you can see I just give you like this P1, N1, P2, and you can easily see the red line, which is for older CI user, they have those delayed peaks, which is what we kind of hypothesize. And we can derive those metrics. Okay, if you look at P1, there's no significant difference between two groups. If you look at like N1, you can see that only at the speech, for the speech sound, we can see the delay for the N1. And also for the P2, you can see across the board, you can see a delay in those responses. So kind of to summarize, think that we see the old adult CI user show this prolonged, as we hypothesize, prolonged P2 latency across all those interstimulus intervals. So I just want to quickly kind of to summarize what I just described about these two studies. They seem to provide evidence that auditory temporal processing, as indicated by a behavioral paradigm and an electrophysiological paradigm, appears to decline with age in this adult cochlear implant patient. Okay. And here I want to say a few things about the clinical implication or some like questions that come out from this. These findings may indicate there may be a need when thinking about like programming the CI device, because one of the important factor or important procedure when you try to programming a cochlear implant, that you need to set the level, the sound level, how loud, how soft you want to have the sound delivered to you. And traditionally, traditionally just using the same procedure for everyone. There's not differential or this older or this younger. So based on this study, we may need there's age specific care in terms of thinking about like programming CI device. You think about from the study one, those old CI users, they may struggle more. We present the sound as a relatively louder levels. They may struggle. It may make their performance like significant job or become worse. You're thinking about that. So there may be a need for age specific care in terms of like programming the device. And also in terms of thinking of the design of the oral rehabilitation strategy, there may be certain type of sound the older cochlear users, they may struggle a little bit more. So we may need to think about like what type of sound or what type of words and we're affected by age-related temporal processing. And the old cochlear, they may struggle more. We may need to pay special attention to those words or sounds when we try to design our oral rehabilitation strategies. So the last thing is that we are seeing this auditory temporal processing deficit. Does it predict spoken communication declines in older cochlear CI users? And can we do something, maybe using audio training to improve audio temporal processing? Would that lead to an improvement in speech perception in older CI users? There's some ongoing studies, but the literature is still like kind of mixed. They may see some evidence, but there's not like consistent solid evidence there. This is just a maybe areas still need to further explore. Okay? And going forward, what I'm more interested in is this. So right now we're more focused on the auditory function. This is just part of the puzzle, just part of the puzzle. What I want to do is to think more kind of holistically, not only thinking about from the input, the bottom input, the auditory function, but also thinking about like the cognitive, linguistic, cognitive function, how those can interact with the bottom up input to kind of support the speech perception. Because just one of the findings from literature is that when you listen to those degraded signals, your prefrontal cortex tend to activate more because the signal is so degraded, they need to exert more listening effort kind of to help them to do speech understanding. So there's this interaction, two-way interaction going on that we need to consider when we think about the mechanism for speech understanding in all patients with cochlear implantation. Okay, so with that, I would like just kind of to acknowledge the funding and also the support from my previous mentors and also the support from the companies that give us the device and of course other patients. And I'd like to thank you so much for your attention. I'm happy to take any questions.
Yes, I have a question. This is Dennis Baker. Can y'all hear me?
Yes.
That's no pun intended there. But I wear hearing aids.
Yes.
You know, and what I think I'm one of the things I'm understanding from this presentation is that for someone like me who's thought to himself periodically that maybe I should talk to somebody about cochlear implants, one of the things I hear you're saying though is that there could be some unanticipated results of cochlear implants which would result in perhaps being disappointed.
Yes.
And thinking that something's going to get better that doesn't. And it really concerned me where you said the dominant cue for auditory emotion perception, which is voice pitch, is severely degraded in cochlear implants.
Yes.
And so does the Institute offer any services in terms of helping a person decide whether or not to go in the direction of cochlear implants? Because I could see where expectations are something that determines whether or not a person is satisfied with the end result. So could some of you just share with me about that in terms of looking into cochlear implants, or should I just, at my point, I'm 70, 78, you know, everything sounds the same to me, you know, and it's a pain, but then I don't want to trade my hearing aids in for something that could not be what I expected and be disappointed and spend a lot of money, although I don't know how much it costs. But anyway.
Yeah, so first, thanks for the question. So our clinic, so I'm at the School of Communication Science Disorders. So our school had the audiology clinic. So they provide those kind of counseling, evaluation for cochlear candidates. So that is definitely a good place to kind of to get a little bit more information. So from my research perspective, I'm not like arguing against getting a cochlear implant. I'm just saying that we're just saying from our finding that there is still a lot of room for improvement. Actually, like there's, because like you said, the voice pitch cues, all those information, and important information may be degraded. So that's, we want to just highlight those. I was more frame it as area for improvement in terms of from our research program, can we do something like training or other things to improve it? And also point out to maybe the engineer folks, medical engineer folks, they can see those room for improvement. Maybe they can do something about it, like change how the device works, provide more cues through the device so that people can benefit those.
Mm-hmm.
So that's, I think that's what I'm trying to say here. Indeed, actually, there's some ongoing work from NIDCD. They're trying to design another type of cochlear implant. Instead of using the electric pulses, that you try to use light. So one of the good things about light is that it's more focused. So which means that it can provide more information, much information, which hopefully can provide a lot of benefit, like emotion perception, music perception. But this is just study ongoing. I think I heard the talk last night is 2 years. They just started the project. They did it. I think they will try to do several on people. They start with like in primate. They will try to do a few like in humans to see if that works. I think that could be one direction I can mention. We highlight those potential gaps in terms of performance, and people can see it, and research from different disciplines, they can see it and they can provide their own ways to hopefully to remediate or solve this problem. I think that's kind of what I'm thinking about, where my research the implication of my research, instead of like argue against getting a cochlear implant. Yeah. But if you need to get like practical information, like our clinic, our school had the clinic. We have 3 in-house audiologists to provide excellent service to hearing aid patient, cochlear patient, also do cochlear implant evaluations. If you need it, you can come to our clinic and then talk to them. Yeah. I hope that answers your question.
Yeah, thank you.
Yeah.
Hi, Zalong. This is
Yeah.
Lei Liu here, one of the engineering guys here. So I'm curious, actually, for this device, this cochlear implants, like this implant, when you put in the body, is it invasive?
Yeah, it is invasive. You need to go through like the temporal bone, open your temporal bone, kind of go through, and then have electrode kind of insert it in your what we call a cochlea, which is like hearing organ.
Right. Looks to me pretty invasive.
Yeah, it is invasive.
Yeah. So my question is that does this cause, injury or inflammation to the body, to the patient, and will that actually contribute to partially to the degradation of the performance of the device or not?
It could be, yeah. Like the electrode, like if you think of, you have an electrode, you have a lot of like fluid around, right? So it could cause a lot of things going on there. A lot of things can happen there. So I would say it's a complex process. There's a lot of like interaction, biological interaction can happen. If you have something foreign object inside a body,
Right,
person's body, yes.
right. Especially like does bleeding occurs often like during this while the patient wearing these implants?
No, I would say this is so first, this is a standard treatment. So which means that it has been very established. But of course, depending on individual person, there may be like a little bit complications, I would say. I'm not a surgeon myself. I just based on the literature I'm reading. This is the standard treatment. Like a lot of people get like thousands of people get it. Like younger, even at younger, maybe at like several months, you can get it for at older as one of the pictures I show in my slides. People 99 years old, like in Europe, this lady get a cochlear implant. So it's a very standard procedure. I don't foresee, at least at the group level, there's like huge, like life-threatening like issues were happening. But of course, individually, there might some slight different things may happen. But in general, I think it's a safe, standard kind of procedures. Yeah, well-established procedures. That's just my understanding. Of course, I'm not a surgeon myself. I cannot say for sure. Yeah.
Long, can you stop screen share so we can see each other a little better?
Yes.
That'll help, I think,
Yes.
for some of the questions. Okay, other questions? I wanted to raise one because, again, I'm not very knowledgeable about cochlear implants. But as you point out, only having 12 to 14 channels, so to speak, to convey the frequency information, which is usually conveyed by, as you point out, thousands of hair cells.
Yeah.
Yes. Membrane.
Yeah.
Really does degrade that.
Yeah.
And do you know why they are so limited to? Is it a contact point issue in terms of where it has to be inserted? It's basically trying to stimulate the nerve, is it?
Yeah, the spinal ganglia, like the cell bodies of the arch nerve. Yeah. So so one of the things that we are the cochlear using electric current.
Right.
Electric current will spread. If you have too many, which they kind of overlap each other, you're not providing like unique information.
Mm-hmm.
So which will not help in any way. That's one of the things I think. Even if you provide 100 electrodes, they overlap each other. You're not providing unique information. It does not help. Actually, one of the things we often talk is that the useful channels for most of the cochlear users only 8 channels. Even if you provide 24, sometimes only like 8 channels may only work. And also depending on the patient the history, some electrode may only stimulate the dead region of the cochlea.
Right.
We are not providing information because there's a dead region cannot receive those information. So yeah. So that's one of the things I mentioned, like now people push toward like one of the ways to push toward using light, because light is more focused. You can have more channels. There's less of a chance like spread of the energy can have overlapping channels. So hopefully more focus, more channels, more information. So that's I think my understanding of one of their goals with this new type of light, like cochlear implant, instead of using electrode. Yeah.
Right. Yeah. It can be much more focused. I can understand that. Again, this is kind of a naive question because I don't know this area, but are people first given testing to find out what might be dead areas so you avoid those when you're doing the implant? In other words, how customized is the surgery?
I think that they do MRI. I'm not sure about other procedures, but in the research side, this is an area of active development. People try to develop those kind of tasks to see if we can identify like dead regions.
Mm-hmm.
I think this area of, at least on the research side, from the clinical side, because I'm not a surgeon by myself, but I definitely like you will have MRI to help you identify, like to guide the surgery, those kind of
insertion,
things.
sure.
Yeah. So, but a lot of more of the details I'm not that familiar with that aspect. Yeah, but definitely in the research side, people try to identify because that's a very, very important area to think about the outcomes.
Right. And then you had also mentioned an interest in MCI, which some of us also have an interest in different research projects, people with mild cognitive impairment.
Right.
To what extent has the research literature looked at cognitive status as a predictor of success of these types of implants?
Yeah, I think this is the area have bring more and more attention. So like I know like my postdoc mentor, they have a project. They just got, I think last year got a one project just focused on like the contribution of the auditory, cognition, and the vision, how those factors kind of work together to predict outcome. I think there's people have become more and more interested in this aspect and more aware of those. But it just, I think one of the constraints sometimes just like I show you the subject, how many number of subjects I can get. And also, if they have some cognitive impairment, we tend to exclude them from the study.
Right.
So
yeah, you're using
that's another layer
for your current work. You're using cutoffs.
because the task we do in the lab, oftentimes, especially behavioral tasks, is, if you want to say it, a little bit boring, and it requires your active engagement, right? Which is a challenge for if thinking about like cognitive abilities. So we tend to exclude that, and we have not much information about how well are they doing, are they getting the benefit they need, those kind of things. I think there's still, definitely people are aware, more and more aware of it, and more research is working toward that, but it just still we need more data kind of to help understand this from. Yeah.
Thank you. Other questions?
Yes. Can you explain a little bit on why kind of like in one of your studies raising the voice to 85 decibel actually hurt with performance? Because, well, I think for most people the default sort of a thing to do for them is when people kind of like can't hear them properly or hear them well, they raise their voice rather than kind of like try to lower it.
Yeah, thanks for asking. So the other explanation is two things. So that's possibly there's a possible interaction between the limitation from the device, and by what I mean is that when you present the sound as a higher level, remember we had the gap for the dish. There's a silent gap, right? There's electric pulses will kind of fill in that gaps, so make the gap less salient. It's just the way I think the electric device works. When you increase loudness, the silent gap, which is a cue for differential sound being filled up to some extent, make this gap, this silent duration cue less salient. That's the limitation of the device. And we did some simulation to look into that, and we actually see that the gap become filled up by the electric pulses, which that's salient. And from a biological perspective, there's study suggesting that basically for auditory system, the auditory nerve, there are different type of auditory nerves. The response for responding to sound of different ranges. There's this low spontaneous fiber. They will respond for the sound as medium to higher level. Okay, so those are the fibers they will respond when you have a medium to higher level, and those fibers tend to decline with aging. The study showing that, a lot of studies showing that those fibers tend to decline with aging. So remember, with aging, they have this loss of those fibers can respond to those higher levels, and then you have this limitation from the device that make the cues less salient. So we think maybe one of the things, this is just our explanation, maybe the combination of those two factors that make the old folks struggle a little bit more because of those biological factors and the device related factors. I don't know if that makes sense.
Can I ask her a little bit of clarification on that? So
yeah,
generally, as people get older, so when you have a complex waveform, or take a chord, something, three very simple stimuli,
Yeah.
and you ask the question about masking, what you typically find is that in terms of fibers, receptive fields, and so on, that a tone that's close to the, ignoring the, if we're just talking about fundamentals and not worrying about octaves, because you get other interactions with octaves.
Yeah.
If you have two tones that are very close together, one will tend to mask the other.
Yes. Yes.
And that masking effect, at least behaviorally, tends to increase with age. And
Yes.
so I would expect as you increase the intensity of your tones, you're also likely to continue to hurt people in terms of the masking effect.
Yeah.
Because if you have a loud tone that's somewhat distant, it may now start to impinge, and you'll get, sort of classical masking effects from tones which normally might not interact in terms of your ability to differentiate them, or at least make use of the information that's present.
Yes, we had one study also try to look into. What we did is we had present a kind of a carrier sentence, and then have those target word differ by cues. You want to see if there is a masking effect for cochlear implant. We do see for some sound there's not for every sound, for some sound there's this masking effect. But because we only have limited sample size, we didn't have a chance. We are not powerful enough to kind of look at the age effect. But this is also part of the grant, like I mentioned from my previous mentor, they are working on this to see if forward masking is one of the mechanisms that can explain like those age-related temporal deficit and the spoken communication deficit. This is like the part of the goal of their grant, the aims of the grant they're working on. So
I see. Okay. We're almost running out of time. Anybody else have questions? We are recording this, and so hopefully we'll be able to post it on the ISL website if people want to go back to it. But thank you again, Long. I really appreciate it. Very interesting presentation. Lots of really striking potential clinical applications that can come out of this type of fundamental research. So thank you again.
thank you.
And thank you everybody for attending today. And we just passed out information about the next brown bag coming up fairly soon. Please try to attend that as well. Goodbye for now.
Thank you, everyone. Bye.